I'm Edwina Brown. I work at the Hammersmith Hospital in London, and I'm going to be talking about adapting PD to different clinical situations. So some of you will be aware of the new guideline that has just been published by the ISPD. You can find it in Peritoneal Dialysis International, or you can find it as open access on the ISPD website. And this guideline is for practice recommendations on prescribing high quality goal-directed peritoneal dialysis. And the statement is that the aim of high quality goal-directed dialysis is to provide the best health outcome possible for an individual on peritoneal dialysis in terms of maintaining their clinical well-being, quality of life, ability to meet life goals, and at the same time minimize treatment burden. And that the principal recommendation is that PD should be prescribed using shared decision-making between the person doing PD and their caregivers and the care team, with the aim of achieving realistic care goals to maximize quality of life and satisfaction for the individual, minimize their symptoms, and provide high quality care. In other words, be flexible. The aim is the person on dialysis. That is what our efforts are directed to maintain that person in the lifestyle that they wish. And we should not be being governed by rules that we have set ourselves. So how do we adapt PD to different situations? So our aim is to prescribe and deliver goal-directed high-quality PD in lots of different situations. And I've just put a few of these onto this diagram, such as polycystic kidneys, frailty, cardiac issues, etc. And why is this important? Well, people on PD see terrific advantages of their dialysis modality. And this data here comes from the PDOT study, which is done across 6 different countries, and they interviewed or questionnaires in over 27,000 people on PD. And to the right of the graph, the pale gray is where people see the factor as a major advantage. Then the next shade of gray is advantage. The dark gray is neutral. The white is they don't know. And then to the left is where it's disadvantages. And as you can see, for predominantly, people see major advantages in peritoneal dialysis, both in terms of receiving treatment at home, not requiring access to blood, in charge of their own treatment, responsible for their own treatment, minimizing time spent at hospital. And all of these are incredibly important in this era post-COVID or during COVID, which has really highlighted the advantage of having treatment at home compared to coming into hospital 3 times a week. People also like the flexibility regarding their PD prescription. The fact that they get less supervision over treatment is also important to them. Less time traveling between hospital and facility, more free time, able to go out and work. All of these are important. When people perceive negative perceptions of PD, then they don't do so well, and that's hardly surprising. So people who have, the more negative the perception, the higher the rate of transfer to hemodialysis or mortality. And this group here is the combination of mortality or transfer to hemodialysis. And negative perception of PD is associated with a poorer quality of life by looking at the physical component score, mental component score, and the CESD, which is a score for depression. So let's think of different situations where PD may be prescribed, but is often not, because people feel that it's going to be too difficult, or that that situation is a contraindication to PD. Obesity, of course, is very important. It is increasingly prevalent in the general population. And obviously there are challenges to providing PD in a very obese patient. So this study, which was published in 2018 in AJKD, comes from the US, over 15,000 incident patients, and what this is looking at is transfer to hemo, death, and kidney transplantation. So the higher the BMI, the greater the chance of transfer to hemodialysis, and the greater the mortality rate with the higher BMI, and slower rate of transfer to getting transplantation. There is also a higher rate of hospitalization for peritonitis in people with higher BMIs, and really no difference across the BMI indexes for hospitalization for other reasons. And looking at mortality, this is looking at people on hemo. It's the same study from the same dialysis chain in the US. People who've got a BMI of over 35 have got a, compared to patients on BMI less than 25. And as you can see, both the hemo and PD patients have really got the same mortality at the end. So let's think about a patient. This is a 38-year-old man who came to see me. He had polycystic kidneys. He'd recently moved into part of London I work in. He was an insurance broker. He had to travel to Australia and New Zealand regularly for work. He had rather overindulged in business lunches, and his weight was now 168 kilos with a BMI of over 60. He wanted a home dialysis therapy. I told him he was lucky that he was seeing me and not anybody else. He was ready to start. His creatinine was 600, he was symptomatic, GFR was 8. So would you actually discuss PD with him? If so, how would you insert the PD catheter? And is he eligible for transplantation? So let's think about those various questions. So here's another set of updated guidelines from the ISPD. This one relates to peritoneal dialysis access in the adult patient. It was published in 2019. Again, it's published in PDI, Peritoneal Dialysis International, and it's available on the ISPD website. So there are challenges in getting catheters into obese people, but with the use of an extended catheter, which is, as demonstrated here, you can get somebody onto PD. So you put in a standard catheter, and then you have an extension line, which is tunneled, so that it either comes out just above the abdomen, abdominal folds, or in some centers, particularly in the US, they bring it right up into the stern, into the anterior chest wall. And we've done a few of these now. What about bariatric surgery? Well, again, that can be done in obese PD patients to get them ready for transplantation. You do need to be careful that the bariatric surgeon knows where the catheter is, so that his laparoscopic ports don't go through the catheter, particularly if it's an extended catheter. So what happened with our patient? He had an extended catheter. He went on an incremental regime, so he was doing 2 exchanges 5 days a week. He had bariatric surgery 6 months later, and he's done very well. His weight is now 93 kilos. It did peak up at 180. He's active on the transplant list, and he's visited Australia and New Zealand. So moving on to cardiac issues. PD and heart failure is quite a hot topic. Some people recommend that you should consider PD in people with refractory heart failure, regardless of whether they actually have advanced kidney disease or not. So heart failure is common in older people. It causes frequent hospitalization, has a poor prognosis. It's often associated with poor kidney function, and you get what I call the seesaw. So you have somebody is volume overloaded, their kidney function looks better. You've got more blood going through the kidney. You then dry them out. They feel better because they've lost their edema. They're no longer short of breath, but their kidney function looks worse. You've got less blood going through the kidney, and somebody panics and they cut back on the diuretics, and hey-ho, you go back again to the situation that you were in before. And of course, this can be often associated with anemia and electrolyte disturbances. But you do need to be, if you're thinking of the seesaw, you can't just use large dose diuretics because you can overdry a patient out, and that can be associated with hypotension and deterioration in kidney function, and your patient feels pretty awful. So if thinking about PD, the benefit must really be greater than the burden. PD or any sort of dialysis is going to have major impact on the patient quality of life and of the family quality of life. There's obviously a risk for peritonitis and potential catheter-related complications. So you should do absolutely everything to improve cardiac function. Use the appropriate drugs, consider intravenous iron to boost the iron status, minimize fluid overload with diuretics. And if you shrink the heart down and get them down to their drier weight, often you get improvement in cardiac function. And use erythropoietin to maintain the hemoglobin. If the GFR is consistently low, I've put less than 15 in question marks because often these people have lost muscle mass, so the eGFR is not very reliable, and there's no evidence about what GFR one should be considering dialysis. But if they've got persistent fluid overload despite high-dose diuretics, or they're requiring repeated hospitalization for heart failure, and they're hemodynamically not compromised, there may be advantages in terms of symptom control, fewer hospital admissions, but probably no effect on survival. Their life is still going to be, life expectancy is still going to be limited by their poor heart. So I'll tell you 2 patient stories. Mr. R, who is a 72-year-old blind man with diabetes with previous coronary problems, he was having repeated admissions for heart failure. He also had evidence of diabetic kidney disease with proteinuria. His creatinine was in the 600s, and he was on high-dose diuretics. We started him on assisted CAPD, 2 exchanges of icodextrin a day. His shortness of breath and edema were better. He then, having had admissions almost every 2 to 3 weeks, he had 4 months with no admissions, and he was found dead in his bed on a Monday morning, having been out with his sister and her family on the Sunday. I think that was a nice ending for his life. Then Dr. B, who is a 63-year-old retired GP who had an inoperable valvular heart disease. So she had right-sided heart failure. Her GFR was about 20, but she'd had 2 episodes of acute kidney injury related to excessive diuresis, and she was getting recurrent painful ascites requiring drainage. So we inserted a PD catheter. She got 1 icodextrin exchange a day, and after a few months, we managed to reduce this to 3 times a week. She had a year of no hospital admissions. She managed her bucket list trip to the Alhambra in Spain, and she died in a hospice. So moving on to surgery, again, a complicated area, but there's been a recent paper that was published in Peritoneal Dialysis International a couple of years ago. So this was a case series and reports that PD can be successfully restarted after really multiple different types of abdominal surgery. But you do need to be aware of initiating PD immediately because of the risk of fluid leakage with the risk of peritonitis and the risk of hernia formation. So the general recommendation is to really work out your plan prior to surgery, maybe increase the dialysis prescription to optimize volume status and electrolytes pre-surgery, optimize the hemoglobin, use a bowel prep to avoid post-surgery constipation, and ensure that the abdomen is empty prior to surgery. And then avoid disturbing the PD catheter, avoid PD for 2 to 3 days to allow some healing and homeostasis, keep an eye on their blood tests, use medications as indicated, and then restart PD using a cycler with frequent low volume exchanges while the patient is recumbent, and then gradually increase the PD volume. Another study from Taiwan showing that, yes, you can do PD in people who've got abdominal adhesions, and this shows identical technique survival in people with and without abdominal adhesions. The ISPD access guideline says similar things. For abdominal prostheses, it reviews reports of PD catheter placements at the time of ruptured aortic aneurysms or as early as a month afterwards without infection, though they do suggest that you allow a minimum of 2 weeks to enable retroperitoneal epithelialization following graft placement before starting PD. Again, with gastrostomy tubes, if PD patient requires a PEG tube, it's recommended that the PD catheter can be removed with staged reinsertion after gastrostomy, has had time to heal, and they quote a higher failure rate of the PDs just suspended for 3 to 6 weeks. But if somebody's already got a PEG tube, then it's perfectly safe to put in a PD catheter as long as the exit site's located remotely from the PEG tube. For polycystic kidneys, PD can be successfully done, whatever their size, even in people who need a pre-transplant nephrectomy. Though obviously such patients, if they've got really large kidneys, are going to feel quite uncomfortable with having fluid in their abdomen as well. And there's a much higher risk of abdominal wall hernias in people with polycystic kidneys. And to prevent injury to enlarged kidneys, then care needs to be taken with laparoscopic ports and trocars, etc. Again, some colonic diverticulosis, which is going to be common in older people, is not a contraindication for PD. And finally, we'll talk about adherence issues. So non-adherence to PD is going to be common, particularly if you prescribe it for 7 days a week. It's one of the reasons that in my unit at Hammersmith, we tend to give people a day off and prescribe for 6 days, so patients know they can take a day off without any harm. So this study from Australia divided adherence to intentional patients actively choosing not to follow treatment schedules, or unintentional, where people just forget. And looking at the factors that were related to adherence, the dialysis non-adherence rates were quite high. It's about 28% of people intentionally, unintentional was 19%. The medication and dietary non-adherence was much higher than with dialysis. In terms of factors that predict non-adherence, interestingly, the more education people have had, in terms of general education, the more likely they are not to adhere to dialysis. So people with a high education level are much more likely to have dialysis non-adherence than people with lower levels of education. So here's my last patient's story. A 56-year-old man on PD for the last 2 years, following 17 years with a transplant. He's got no donors, and he's on the active wait list. He alternates CAPD and APD depending on his work schedule, which involves travel. He started a new relationship a few months ago, travels a lot, misses days, stays overnight away from home. He'd had a split line in Madrid 2 weeks previously, and only told the unit when he returned back to London. And he's seen in the clinic and he's fluid overloaded, high creatinine, etc. So would you continue him on PD or persuade him to transfer to hemodialysis? Do you think referring him to a counsellor and better psychosocial support would be helpful? He himself has asked for a second APD machine at his partner's flat, and should we actually provide this? So in answer to these questions, he really did not want to transfer to hemodialysis. We did refer him to a counsellor, and we did provide him with a second APD machine. And he managed a few more months on PD with better adherence. He then became severely fluid overloaded and hypertensive again, and we persuaded him to transfer to hemodialysis. Fortunately, 3 months after that, he got a transplant off the wait list. So PD can be adapted to many situations, and the way one should do that is really thinking about how to deliver a goal-directed, high-quality dialysis with shared decision-making with your patient and their family. Thank you.